Next, we're going to move to topic number 7, which is the last one about geriatric assessment and the Medicare wellness visit. This applies more for really, when you are in the United States to get reimbursed and perform the assessment as required by Medicare. But I think it's still useful if you, no matter where you are, if you do these elements when you do history and exam with older adults. So you can perform a risk assessment. You want to ask the patient what they think their health status is. You want to find if there are any psychosocial risk. Sometimes people forget that, older adults do have sex, that they may engage in, behavior that may be risky as well. Drinking, drugs, tobacco, they're, having multiple new sex partners. You want to, again, find out what their instrumental activities of daily living are. You want to look at their medical and family history and their pharmaceutical history. Again, a targeted family history, how long their family members live. Do they have a history of family impairment in the family? Do they have any end-of-life experiences with their parents and siblings? And, it used to be in the older days, more people died at home, and now more people die in facilities. So they may not have had experiences of having a family member die in the home. You again want to look for any potentially inappropriate medications. You want to screen for depression, as we talked earlier. You can use a PHQ-2, the 2 questions, and then if that's abnormal, then move on and do the 9 questions. There's also another scale, the Geriatric Depression Scale. That's a 15-item scale. The only thing I don't like about that one is that there's a few questions that may be hard to answer for people, that maybe not representative of depression for people who have a serious condition. Like, are you afraid something bad's going to happen to you? And then it's like, well, yeah, if I have cancer, so they may not apply for some of the people who are sicker. But it's still, again, this is a screen, so if you have 6 questions, doesn't mean that you're diagnosed with depression. It just means you need to go and ask more questions and assess what's going on. Again, when you're screening for functional status and safety, then you're addressing if they're needing any help with their activities of daily living, or have they fallen? Do they have any hearing loss? And then, you want to assess the home safety, give them a tool to look at. And you want to screen for the urinary incontinence, as we talked about the question of in the past year, have you lost your urine and gotten wet? You also screen for weight loss and malnutrition with the question we talked about, have you lost weight in the previous 6 months? So here are some of the elements for the Medicare annual wellness visit. And just because you have to do it, that doesn't mean that it has to be all done by the physician. You can train your staff to do some of this. For example, obviously your staff will do the weight, height, and blood pressure. You're going to address the cognitive function. You can do the mini cog tool, and then if the mini cog is positive, then you can do the MOCA do the time, get up and go, and then do age appropriate prevention and prescribe immunizations if needed. And here's this table has some suggestions about what healthy lifestyle and counseling you do based on the life expectancy. So obviously, if they're near end of life, then this is not the time to emphasize you need to stop smoking. But however, if they do have more than 10 years of life expectancy, or even 5 to 10, you still want to address the smoking cessation and offer options for stop smoking, because it'll still diminish the damage if they stop smoking or smoke less. Now with the Moderate dementia person, this is something you may want to discuss with the caregiver. Obviously the demented person may not be able to go buy their own cigarettes, and you may want to weigh in the um, risk benefit in there. Make sure that they're being supervised so that they won't start a fire because they're smoking. So something to discuss. As far as exercise, you want to recommend exercising. Now, in the end of life, this is something they may consider depending on what they can and cannot do. But, there's always, I like to say the endorphins, which is the substance released when you exercise, is the best type of feel good and pain relieving medication. So I'm a fan of exercise. Alcohol misuse, you want to talk about. Driving assessment is something that you may have to consider. Some of the older drivers may not be as safe, but you may want to at least ask. And especially the dementia person, you're going to ask and assess, because there may be a point where you're going to have to take their keys away. And then as far as sexual function, again, you got to remember old people do have sex, so you want to ask about it and make recommendations as needed. As far as, pretty much in all the categories we've been talking about, you do want to do your incontinence screening, the visual, hearing, cognitive impaired, gait imbalance, depression, and fall risk assessment. And then no matter what stage you are, advanced directives, you always want to make sure that they're updated and complete, and revisited, because sometimes, you may think right now that if you need somebody to clean your bottom and put diapers on you, that would not be worth living, and maybe you get to that point and that's not how you feel. So people do change how they feel about things, so you want to kind of revise. Here are some references. They're linked to the article, and some of the links to the tools that you can use in doing the geriatric assessment. I'm sure you'll have access to the presentation, so you can look at those with more time. So the